2021. This is Dr. Ara Deukmedjian, CEO and founder of the Deuk Spine Institute. We're getting ready to broadcast live spine surgery. This morning we're going to be performing a procedure called the Deuk laser disc repair, which is endoscopic spine surgery. And our patient comes to us from Indianapolis or Illinois, right? You guys are from Illinois? And she has a herniated disc at L5-S1 with back and left leg pain. And when you look at the MRI, you can see the herniation is in the foramen on the left side at L5-S1, and it's pushing on the nerve root very badly. So she's had horrible pain in her back and down her left leg. All right, Dr. Deuk here. We're going to get started, okay? All right. If you have pain, I want you to say ouch, but don't move your body around. We have straps on? Okay. All right. Are you comfortable? All right. So you're going to be awake for the first 10 minutes, and then we're going to put you to sleep, okay? Before we get started with the surgery. All right. And if you feel pain, you can say ouch, and I'll give you some more numbing medicine. Right now, I'm just feeling around. I know Dr. Patel did the piriformis, so I'm just kind of palpating. You're going to feel a little stick and burn. That's just the numbing medicine going in, okay? So a lot of surgeons would end up doing a microdiscectomy for this type of an injury, and it would be the wrong procedure, 8 cc's. Because a microdiscectomy is used to treat herniations that are paramedian, which means between the center and the foramen. They're not good for foraminal herniations. And the only way you can get a foraminal herniation with a microdiscectomy, which is still what 99% of the surgeons would do, is by removing more of the facet joint and the lamina. So that would destabilize the spine even more. Remember to let me know if it's uncomfortable, okay?
We have long here. Right there, doesn't get it.
You have the long one?
You want to just...
No, we may.
Oh, yeah.
Shot? All right. Good. Let me, I'm going to stand where you are, so you're going to have to move. Okay. And let's bring our lateral fluoro in. So the wrong surgery would be a microdiscectomy or laminectomy, but that's all most surgeons know how to do. The best surgery is the endoscopic surgery we're about to do. It's called endoscopic transforaminal surgery. And we developed this surgery at the Deuk Spine Institute, and it's different than most endoscopic surgery. You're doing fine, just relax. You want some more numbing medicine? Yeah? Just lay still. I don't want you moving. Okay, the deal is if you feel pain, you say ouch, but don't move around. All right, we can't have you moving. We do need you awake for just a few minutes, and then we'll put you to sleep, okay? My promise. I just have to safely get down to where your herniation is, and then we can put you, no, just lay still. Shot. All right. I need your help, doctor. AP. All right. So we need to probably going to have to reposition the fluoro because she's moved. Yeah, you're doing great. Just relax. Everything's okay. Go back to a lateral, please. You're going to have to reposition the lateral. Yeah, let's get that blood pressure down. So just to review once again, we have a herniated disc at L5-S1, left side. It's in the neuroforamen, pushing on the nerve root called the L5 nerve root. All right, that's much better. Let's see if we could maybe drop the table. I'd bring the fluoro north by 1/2 inch. I'd drop the table possibly 1/2 inch. Let's go. Fluoro north 1/2 inch. Did you do it? That's it? Shot? Otherwise, your wag is nice. Very nice. It's very pretty. All right, let's try to keep that. So the beginning of the surgery is really about navigating. I like to talk about navigating like a ship would navigate from one place to another. And we're basically navigating down to her spine. And we're navigating to a specific place in the spine. All right? So, for example, when a ship navigates to a country, it's going to not just go to the country, it's going to go to a very specific port where it can lay anchor or tie up to a dock and unload its goods or transact business. Hello, I need you. Come on, that's you. All right? So we're not just navigating to the spine, we're navigating to a very specific place. And it's literally a place that's a millimeter target. And that is the tear in the back of her disc, right where the herniation is. So I need to use information like the fluoroscope to navigate there. And I also need to use information like the patient telling me. All right, I need the patient to say, oh yeah, that hurts. I feel pain in my back. I feel pain in my leg. Where do you feel pain? Don't move. Don't move. Where? In your butt? All right. Yeah, that's where we're working, okay? We're almost done. We're going to put you to sleep soon. You just need to behave for a little bit longer. All right? We're a team here. We're almost where we need to be. Shot. So I can feel the facet. Let's get an AP just to verify. And you can see I'm targeting the L5-S1 disc. Don't move, all right? You're doing great. Now, we cannot use numbing medicine down by the neural foramen. Okay? If we use numbing medicine down by the neural foramen, we're going to numb up the nerve root, and then we won't know if we're too close to it. We don't want to numb up the nerve root. All right. Very good. You're doing great, by the way. Everything's going well for you. Okay? Sean? You're good. You're good. Did you have back pain at all? You get back pain, right? Yeah, I think her leg is the biggest problem, but she does get back pain. Marker. We're not ready for that, okay? So put that down. I don't know why you're grabbing that. You got to learn the sequence. All right, so the disc we're targeting is L5-S1. I'm going to draw it here on your back. You get to watch your video later. Your husband's watching as well. So you got a herniation here on the L5-S1. And you get to relax. I'm just going to talk, okay? Now, when did your problem start with your back pain? How long ago? How many years? 6 months. So prior to 6 months, you never had back pain? Never. All right, so what we should be dealing with then is a soft herniation because it's only 6 months old. Is that where you typically get your back pain? How bad was that on a scale of 1 to 10? Huh? It only went to a 9? It didn't go above a 9. What was the highest it went to? Yeah, it's 10. All right, I have good news for you. You get to go to sleep now. And when you wake up, your surgery will be done and you'll be recovered. Congratulations. We found the bad disc. So basically, she has a tear in the annulus, and the jelly in the center is pushed out through the tear, and it's actually pushing on the nerve going down her leg. That's the L5 nerve root, okay? Because it's a far lateral herniation, it's going to hit the L5 nerve root, even though it's the L5-S1 disc. So everyone's taught the basics of spinal anatomy. L5-S1 herniation affects the S1 nerve root. This is the S1 nerve root, this is the L5 nerve root. The L5 nerve root exits the foramen right where the herniation is, and if it's a lateral herniation, it'll get it. So she had 10 out of 10 pain at L5-S1 for her back pain. So that back pain will be gone, as will her leg symptoms. You can see a big tear in the back of the disc. All right. The back pain that she's having comes from the tear in the back of the disc. Shot? Now we've got the guide wire in. And so we're going to remove our needle because we're done. And we've successfully navigated from the origin where we started our journey, which is out here in the operating room, specifically right here on the skin. And we've navigated down to our port of call, which is the L5-S1 left-sided annular tear within the neural foramen, okay? That's not blue blood. You might be tempted to think it is, but that's the dye we use in the discogram. She asleep? We're going to make our incision. The whole surgery will be done through a 7mm incision. Okay, 7 millimeters, no bigger. It's a 1/4 inch, basically. And we'll lose probably a drop of blood, maybe a few, but usually not more than a couple of drops of blood. So the human body has on average about 4.5 liters of blood, depending on your size and things like that, but anywhere between 4.25 and maybe 5.25. And we're going to lose less than one drop. So that's 4,500 liters of blood. We're going to lose less than one drop. I mean, one milliliter, which is 20 drops. 1 milliliter is 20 drops. So we could lose 20 drops of blood and still be under 1 mil. All right, lateral. So we're basically making our way down to that herniation at L5-S1, following the guide wire. And you can see the guide wire is coming out the back end of this dilator, okay? So we are now in the foramen. I can feel the herniation. And I'm going to try to push this herniation back in the disc where I can retrieve it safely. Okay? So I'm pushing the herniated nucleus back through the tear and back into the disc. We call it a reverse herniation. All right, now I've done what I can do using my fingers. I'm going to advance this dilator through the tear, pushing the herniation in along the guide wire. All right, and there you are, we're inside. Now it's really easy to get in because the tear is pretty big. So I'm going to advance it a little bit more just so I'm really where I want to be, just embedded. You don't want to go past 2/3 of the distance across the vertebral body front to back. That's about 2/3 right there. Now we're going to do the entire surgery through this endoscopic tube. It's called the tubular retractor. And the whole surgery will be done through the center of this thing. It's like a McDonald's shake straw, just made out of metal. And they're pretty strong, but we had the last lumbar laser we did on a Canadian patient. He actually was so powerful with his muscles, he crushed 2 of my tubes, right? Two of them. I mean, yeah, that was incredible. But he had really collapsed discs, which this patient doesn't have, by the way. And he had just really big paraspinous muscles. All right, it's looking pretty good right there. Shot. Great job, Jordan. We're inside the disc. You can see the tube is in, and we're ready to get started. So look how much blood we've lost so far. That's literally like not even a nosebleed. If you have a nosebleed, you're losing more than that. And that's pretty much all the blood loss we're going to have for the whole surgery. So it's Deuk laser disc repair. Endoscopic transforaminal surgery is bloodless, and there's no narcotics needed after surgery, no opioids. People take a little anti-inflammatory and a muscle relaxer called Flexeril.
Give it to him. Nope.
We need the fluid adapter first. All right. I think you guys spend more time setting this room up than we do actually doing the surgery. All right. Well, I'm a big believer in preparation, so. Okay, we are ready to rock and roll. Let's show them the scope. Zach, can you show them the endoscope?
They can see it.
All right, so take a look at this thing. It's pretty cool. So we've got this tube going in right through the tear, So there's no damage to our patient's body except for the incision in the skin, which is like nothing. Okay? So 7 mm incision, and then what we've done is we've spread the muscles and tissues under the skin without damaging them. There's no damage. And then we get to the herniation and we touched it and shoved it back in through the tear. And now I'm going to take the pieces out from inside the disc, and at the tear I'm going to do a debridement. And all that's done endoscopically using this beautiful endoscope. Now here's the problem. 99.9% of spine surgeons in the world don't know how to use this. They're not even familiar with this technology. They don't even know it exists. And all they're doing are big open surgeries and moving all the muscles and tissues and cutting bone and removing ligaments and bone out of the spine just to get to the herniation. And then they have to fuse with screws and rods. So this is a much more advanced technology, and her husband found us, and he's a chiropractor, and he didn't want her to go through open surgery. He wanted her to have a much better surgical option. This is the best there is in the world. All right, going down, here we are. We're inside the disc. You can see some of the inflammation going on already within the annulus there. And now I'm going to start pulling the herniated fragments out. Hopefully we'll get a nice big one, and then we'll be able to high five each other. When you get a big fragment out, then you've done a good job, and you feel more confident that you've gotten the pathology that's causing this patient's symptoms. Remember, the fragment is not causing the back pain, it's causing the leg symptoms. The back pain comes from the annular tear. Now, she had predominantly leg symptoms because her nerve was getting crushed so badly. There's a piece of herniation. That her primary focus of her brain was on her leg. And that happens when the nerve gets crushed severely, like hers was. Now the problem is, if you don't fix crushed nerves, they can get permanently damaged. So nerves are delicate. For those of you who've never touched or seen a nerve is a lot like a pasta, like spaghetti. If you cook the spaghetti al dente, not even al dente, it has to be more than al dente. You're at 30?
30. Yes, sir.
If you cook the pasta, to where it's kind of soft, past al dente, then that's what a nerve is like. And if you squeeze the nerve hard with your fingers, like you squeeze the pasta, you can actually squeeze right through the nerve and cut it in half with your fingers. Easy. Just like a wet, cooked pasta. That's the consistency of nerves. So these herniations can actually do a lot of damage to the nerve when they're left there. So we didn't want permanent damage, so we acted quickly. And here she is having her surgery done. Now the debridement I'm doing to the annulus is the key to eliminating back pain, but also the key to healing the disc so she doesn't get a recurrent herniation. Okay? Now the annular debridement that I'm going to do here, that I'm working on, is actually not done in any other type of spine surgery. Only the Deuk laser disc repair currently is the only surgery that does the annular debridement.
We have a question.
Sure.
We have a viewer asking, I'll be going in for P-lift surgery on my L5-S1. How severe is this type of surgery?
How severe is T-lift surgery?
P-lift, P-L-I-F.
Yeah. Well, it is pretty major surgery. Why don't you show them, Zach, a comparison of the laser that we're doing now versus a P-lift. We have a video that will show you the difference. Zach, can you run that video? Zach's going to look for that video and show it to you. Basically, this surgery, if you do this surgery, you don't need the P-lift. The P-lift is overkill. And the problem is most surgeons don't tell you that because they don't know about this surgery. They don't know that it exists. They don't know how to do it. They don't have the equipment to do it. They don't have the technology or training to do it. So, you know, technology really reigns supreme. And the better the technology, the better the chances of success, and the lower the, these are all pieces of herniation, by the way, the lower the chances of complication. Because this surgery is so minimally invasive, there's no bleeding, there's no instability created from the surgery by removing bone and ligaments like you get in a PLIF, a PLIF. PLIF stands for posterior lumbar interbody arthrodesis. And for a long time ago, that's all I did was PLIFs and TLIFs, which is a, TLIF is a transforaminal lumbar interbody fusion. PLIF is a posterior lumbar interbody fusion. They're basically the same surgery, but a PLIF puts 2 cages in rather than one on each side. So you can see all the damage done to the disc. It's just fragments of herniation. So I've got to grab out as much as I can. I'm going to use the laser to clean up the tear. You can see the annular tear right there. So we're going to clean that up. Laser's on, correct?
Yes, sir.
All right, see if you can run the video showing the comparison of a open TLIF PLIF surgery versus Deuk laser disc repair. A video is worth 1,000 words.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed.
Deuk, back with you. Hopefully you could see the difference. But basically, to summarize it, the Deuk laser disc repair here that you're watching is a better option than a PLIF or a TLIF, okay? Any kind of fusion surgery. Number one, this TLIF or PLIF surgery gets rid of usually about 50% is what the surgeon will tell you. 50-50 on the back pain. The Deuk laser disc repair gets rid of 99% of the pain. So 50% versus 99%. This surgery, the recovery is an hour. The P-lift, the recovery is going to be about 3 months. So think about that. Because this is a tiny incision, we're not doing any damage to the spine. So the body heals very quickly. The only thing that takes a long time to heal is the actual disc. She's responding a little bit. Now the P-lift, you're going to be done at the hospital, and of course there's all kinds of problems with hospitals in terms of getting infections at hospitals like COVID and other complications like pneumonia, blood clots in the leg. We actually did a little video yesterday on a patient who had blood clot in her leg after a fusion. Then it went to her lung. So she had to be put on blood thinners for 6 months. And we were talking about that in one of our reaction videos that we'll publish soon on our YouTube channel. So the PLIF surgery is painful, and you will need narcotic painkillers, opioids, for months afterwards. How's our irrigation? Well, don't overinflate it. So the P-lift surgery is painful, and it's going to take a long time, months if not years to heal. So this surgery, on the other hand, you're healed up very quickly. Usually within a day. This patient you'll never be able to tell she actually had surgery. It's interesting, right there, that white stuff. That white stuff right there is typically what I see when somebody has a steroid injection. I don't know if she had a steroid injection. Yeah, no, I'm talking about an epidural. I'm talking about an epidural. Yeah, that looks like an epidural steroid injection. That looks like Deukmedjian. Because Deukmedjian has a like a preservative in it. You're really not supposed to use it for epidural because it can actually cause scarring, and if it gets into around the nerves, you can get a toxicity. So, but a lot of pain management doctors use Deukmedjian because it's cheap, and they want to save the money. You don't get less money if you use Deukmedjian. We don't use Deukmedjian here at Deuk Spine because it's not safe. We use Decadron usually, Solumedrol, preservative free. All right, I apologize for the cloudiness, but that's just a little bit of bleeding from right there where there's some inflammation that was there. And it reminds us that this is an inflammatory condition. Herniated discs and pain from the herniated disc is inflammatory. It's due to the inflammation in this area. And she had a lot of inflammation here because she had a lot of pain, and the pain indicates inflammation. This is all herniated disc right here. And yes, this looks like it could be 6 months old. That's for sure, which is when she said her symptoms began. So I got to remove as much of this as I can to unpinch her nerve. Now, by also debriding the annular tear, it allows her disc to heal properly so that she doesn't get another herniation. So she just has to be real careful while it's healing to allow the healing to be completed. It takes a year to fully heal one of these because the annulus doesn't get much blood supply. Let me have a grabber. Laser off. Okay, you can't, don't fumble around. Just open your finger and close, okay? I'll put it where it needs to be. So, this instrument I'm using is called a pituitary rongeur. Look at all the fragments of herniation. So, that's an indication that this didn't happen too long ago. Because with older herniations, there's scarring. And they don't float around like that. They stay clumped together. So, the timeline of her injury is consistent with what I'm seeing here endoscopically.
If you push against it, it's gonna break the tip. Alright, so leave it.
Thank you, Luis. All right. Now you can also see that the grabber is not a very good tool at removing herniations that are still stuck down. It's a good tool for removing herniations that are loose and freed by the laser. So for those people who say laser is not necessary for spine surgery, honestly, they have no idea what they're talking about. Because if they actually knew, they would know how valuable the laser is. The laser is precise. That laser fiber you're looking at, the little glass tube at the end, that is 0.5 millimeter, 0.5 millimeter, 0.5 millimeter. So think about the precision of this treatment, how precise it is when you have 0.5 millimeter surgical instrument. Can't beat that. Everything else is clumsy that we use. It's big and bulky and clumsy compared to the laser. And there aren't many surgeons that know how to use the laser on the spine. Very, very small number. Like literally in the United States, probably just 2 or 3. Certainly less than 5. Now, does that mean people won't market with it and say, oh yeah, we do laser surgery, but they actually don't? Ask them to show you videos of the surgery. Here we broadcast all of our surgeries live. You can see what we do. And I use a laser on every single one of my Deuk laser disc repairs, and I use the laser for the whole surgery because it's a real tool, and it's a really good tool for fixing things in the spine. As a matter of fact, I couldn't do these surgeries without it. That's how valuable it is, how important it is. All right, so we got a little bit of epidural bleeding, a little bit of fat right there. That's like microscopic because think about it, those little capillaries that are bleeding right there are smaller than the laser fiber. And the laser fiber is 0.5 mil, 0.5 millimeter. So those little capillaries are almost releasing red blood cells that you can pretty much see. All right. So everything's going well for her. This is the L5-S1 disc in case you missed it. Zach, will you play the Deuk laser disc repair animation so people understand what we're doing here with this annular tear and disc herniation? Will you cue that up and run it, please? Let's have the grabber.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
At the Deuk Spine Institute here in Orlando, near Orlando, Florida. We're located very close to SpaceX. How far are we from SpaceX? Probably 10 minutes? All right. So about 25 to 30 minutes to the base. So this is the Space Coast of Florida where we are, and we've been here now since 2004. That's 17 years. Deuk Spine Institute has been here practicing and performing state-of-the-art spine surgery. Now, I used to do a lot of fusion surgeries. That's how I was trained at a top spine neurosurgery training program. And over the years, as I've learned the value of this technology with the endoscope, we've done more and more endoscopic surgery and far less fusion surgeries. Does that mean fusions don't work? No, fusions can work if they're done right. However, fusion is much more invasive and a much longer recovery, much more painful, much more bloody. Everything about a fusion is worse. Adjacent segment disease, scar tissue, screws and rods, cadaver bone, losing movement, open invasive surgery, removing bone and ligament from the spine. All those are negatives, and this laser surgery we're doing has none of them. This is the most natural way of fixing a disc injury, and that is to debride it and then let it heal on its own. Let it heal properly. Don't move that. This is lateral in the foramen here. Any questions from our audience? We're just about done.
We do have one. We have a viewer who says, I had a disc herniation about 5 years ago, resulting in extreme pain. It subsided after some pain meds and muscle relaxers, but I was left with drop foot, severe drop foot. After more tests, the docs decided to take a wait-and-see approach. 5 years later, no change. Is there any treatment that could reverse the drop foot?
Yeah, great question. So it's a bit of a sad story, but at the same time, there's still hope for you. So whenever a patient has a drop foot or any weakness from a herniated disc, the wrong thing to do is to wait. Always considered the wrong thing to do. But the problem is a lot of surgeons wait because they're scared. They don't feel confident in doing the surgery. They're worried about a complication. They're worried about the patient. Maybe the patient rubs them the wrong way. But there's every excuse in the world that I've seen surgeons come up with for not fixing that. The drop foot or weakness should always be fixed 100% of the time. And it should be fixed immediately without waiting. The sooner you get that nerve unpinched, the greater the chance of making a full strength recovery, okay? So among really good neurosurgeons, we all know you're supposed to operate right away and get the nerve unpinched. So to answer your question, the waiting should not have happened, but it may not be too late. I believe we could still fix the problem. And honestly, you should try because you never know until you try. So I would give you about a 50-50 chance, without even seeing your films, a 50-50 chance that you can get your strength back if you were to get this treatment you're watching right now, the endoscopic surgery. 50-50 chance. Now, if you don't do surgery, I can guarantee you 100% you're not going to get better. Grabber, you're not going to get better on your own. So would you rather have a 50-50 of getting better or 100% you're not going to get better? I know what I would do. I mean, it depends on your lifestyle, but most people want to be able to be normal and have normal strength. I mean, some people they just want to sit around and do nothing all day, and they're happy with that, but that's not most people. Most people want a normal life. And if you want a normal strength in your foot, the only way you're going to get that is by doing surgery. I hope that answers your question. All right, a little bit more lasering and we'll be done. You cannot do that. Okay, you can't trap my fingers. You must take it straight off. My fingers won't bend. Just about done. There was a lot of damage to this disc here. It didn't come out in one piece like I would have liked it to. It coming out in multiple pieces. Of course, I have a little fumarole Okay. Let's see what we got left. And the reason there's some bleeding here is, remember what I told you earlier, this is an inflammatory condition. So she had compression, but all disc herniations are inflammatory, meaning they elicit inflammation. And inflammation brings blood flow, blood supply. So it's the inflammation that makes it bleed. Just like a zit is red, it's red and swollen because of the inflammation. There's blood there. This is like a aseptic zit in the lower back. All right, let me just bring the grabber one more time. And I'm going to bring the grabber because it helps stop the flow and it allows me to see things better. Okay, there's the epidural space. The nerve root is right there. You see that? That white thing? I could probably get that little bit right there that's left. It's not really causing a problem, but I don't want it to. I'll use the laser to do that. But pretty much the nerve is decompressed. Don't move. All right. We're pretty much done here. Looking back, that looks good. Do just a little bit more. Okay, guys. You're gonna do a stitch? All right, and where there was a giant herniation, there's now nothing. And this should heal nicely for her. She just needs to take it easy. All right. Done. Scope off. I'm going to show you in just a moment what the incision looks like. But first, a little antiseptic. Now, we used to use bacitracin for many, many years in surgery as a topical antiseptic, you know, to get rid of any kind of fungus or bacteria that could have gotten in during the surgery, which we don't expect there to be any, but that's what we used to use. I'll take it back one more time. So we use a little betadine bacitracin, and now I irrigated that out. Okay. How's she doing? All right, so we're done. Watch the scope. Can you all see this here? Let me have the marker. So just to recap, she has a herniation at L5-S1, which we've removed. She had 10 out of 10 pain at this disc, so that was causing a lot of back pain for her. But her main problem was the leg pain on the left side. We got all that herniation out. Now, had she had a normal microdiscectomy, they would have opened her from here to here, a big incision, because she's got a lot of soft tissue, and that would have been a very painful surgery. She would have had a lot of bone and ligaments taken out of her spine just to get down to that herniation. Okay? A lot of people don't realize that. A lot of people don't realize, that traditional spine surgeries, you don't break that, please. Do not drop that scope or it would be really bad for you, I can promise you. That's about $25,000 right there. All right. A lot of people don't realize that traditional back surgeries cause massive damage to the spine, to the normal parts of the spine. The surgeon has to get down to the herniation. To get there, they have to take bone and ligaments and joints out. That's why if you look at the code 63030, which is a microdiscectomy code, the surgeon includes laminotomy, which is making a hole in your lamina, which is a bone in your spine. And then partial facetectomy means taking out part of your facet joint. Usually they take 50% or more, and that's going to cause your spine to fall apart. I've seen it happen so many times. And surgeons don't tell you about it because they think that there's no other option. Because everybody does microdiscectomy, there's nothing better. They don't know something better exists. So that's all they do, is they keep recommending the old surgeries that have been around for, 100 years. Even though there's much better surgeries available now, they just don't know how to do them. That's why we broadcast, so people can learn the truth. All right, no complications, EBO.
Disc herniations are a
1 mil.
common cause of chronic back pain.
This was a left DLDR, Deuk laser disc repair, L5-S1, and a left piriformis, which Dr. Patel did before I got here.
Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
endoscopic spine surgery at L5-S1 on the left side for a foraminal disc herniation. And a lot of surgeons that do endoscopic surgery, they don't do L5-S1 transforaminal because they can't. It's very hard to do. However, I've been doing it now for 15 years here at Deuk Spine Institute, and we've been able to treat virtually 99% of the patients that have a L5-S1 herniation with the transforaminal approach. Just so you understand what that means, by a transforaminal approach, we are going and fixing the herniation by going through what's called the foramen. That's the foramen, and the reason why L5-S1 is so difficult is because there's an iliac crest here, a bone that's not part of this model, and you have to come in, you might hit it, and then you got to get in and fix the herniation there, okay? So most endoscopic surgeons that do endoscopic surgery, they do L4-5, which is this one, the next disc up, L4-5, and above, up to about L2-3. So they do these 3 discs. We do at Deuk Spine all discs. We don't discriminate based on the location of the disc, and I've been able to get into L5-S1 almost every single time. There have been a couple of exceptions. So this patient had a foraminal herniation, back and leg pain. We confirmed her back pain was from 5-1 with the evocative discogram, which was done in the beginning. And I think her back pain is going to be gone. Her leg pain should be gone. I think she'll be very happy. So she'll be in a back brace for 6 weeks. She'll be restricted not to bend at the waist for 6 weeks and not to carry anything over 25 pounds. But she'll be going home in about 30 minutes from now. Since there are no questions, check out the Deuk Spine Institute app. You can download it to your phone, and there's a lot of good information in our app. It's free. Also, if you know somebody with back or neck pain, thoracic pain, get their MRI uploaded on our website, and we'll do a review for free. No charge. Okay? Have a great day.